morning, everybody. Before I begin to talk about my journey with PMP, I have to take this opportunity to thank the doctors that are here today. Your dedication, your research, and your continuing effort to try to solve a very complex problem, this PMP cancer. I really do appreciate some of the levity that some of the doctors use in their presentation, because a very important part of getting through PMP and the treatments is having a positive attitude. And I hate to say it, to be humorous about it, but you really have to be positive. You have to fight the fight and just try to stay as strong as you can. I'm currently a 7-year patient of Dr. David Bartlett at UPMC Cancer Center in Pittsburgh. I've had 2 chemobaths in PMP patient land. We call it MAOS, the mother of all surgeries. Most of the patients that are here understand that term. But my journey began, I live in Greensburg, Pennsylvania, which is a suburb of Pittsburgh, about 30 miles east. And the hospital community out there is called Excella. And in 2004, when I was 46 years old, I was suffering symptoms of what I thought was a bladder infection, which is sort of rare for men. Went to my PCP and he prescribed antibiotics. And it relieved about 90% of the symptoms that I was having. But it just didn't take me the whole way. One morning, about 6 weeks later, I was laying in bed and I just felt uncomfortable in my abdomen and just feeling around. I hit a spot that was very painful. So I called my PCP and he said, I want you to get in here right away. He examined me and he sent me for a CT scan. I had the scan at 12 o'clock that day. The next day, 1 o'clock, I was in the emergency room. I had a tumor that was 9 centimeters large that was leaning up against my bladder and against my sigmoid colon. And also it was leaning on the right ureter, leading to my bladder. So after 5 days of extensive testing, the general surgeon had no idea what they were dealing with. They brought in a urologist. He had no idea what was going on. So prior to surgery, they wanted to insert stents into my ureters just to protect the ureters. And when they did that, they were taking pictures inside the bladder, and I actually had some of the tumor that invaded the bladder. And they had pictures of it that were sitting inside. So the next day I had surgery, 12-hour surgery. Unfortunately for my wife, Karen, who's here today, the surgeon brought her in after the surgery and said, I've done everything I can do. I had to leave some tumor inside of him because I don't know how to extract it, but we don't know what we're dealing with. And lucky for me, I knew the local oncologist. He was a friend of Dr. Bartlett and has done some work with him in the past. And he said, I have the guy you have to go see. And so don't worry about it. He'll take care of you. So after I recovered, probably about 6 weeks later, I went down to see Dr. Bartlett. And I actually saw Dr. Zay first, who was one of our first recipients of one of our research grants. And he told us that, look, you have what's called PMP. He gave us the big word. Didn't mean anything to me. I've never had to deal with cancer in my family. We have no history of it. It was a pretty scary time. But he was very reassuring. He said, in your condition, you have to treat it like you have diabetes. This stuff will not kill you because of the condition you're in and the treatment we're going to give you. And so that was very reassuring. We left with, I knew I'd faced some big surgeries coming up, but I knew that at least I had some hope. About 4 months later, I had the first MAOS, mother of all surgery, the IPEC. That was in December of 2004. At the time, I had a colostomy, and he reversed it to an ileostomy. So 8 weeks after that, I had the ileostomy reversed. Started on quarterly appointments with Dr. Bartlett. 8 weeks after I had the ileostomy reversed, they put me on 6 rounds of FOLFOX chemotherapy. I was also told that 1% of patients have permanent neuropathy. I'm a lucky guy. I'm the 1%. I have neuropathy in my feet that I've been dealing with for 7 years, and I can't get rid of it. I've tried everything that they've recommended, and nothing works. First 2 years, I was on a quarterly appointment basis with Dr. Bartlett, and he always talked about when it comes back. And after the first 2 years, I went to a 6-month schedule. And after the next two meetings with him, he started to talk about if it comes back. Yeah, I was starting to get comfortable with going to see him. Unfortunately, I had my 5-year anniversary appointment with him, and had the scan. He came in, he read it right away, and he said he sees no evidence of the disease, and he doesn't need to see me any longer. Boy, I was happy. I couldn't believe it. Got through my 5 years, and here I am. And luckily, his PA was sitting there, and she said, I don't know if you should tell him that until we get the final results from the radiologist. And a week went by, and I'm driving home from work, and my cell phone rings, and it's the PA from Dr. Bartlett. She said, you have a moment to speak. And I said, well, you just tell me what's going on. And she said that the radiologist found a 1/2-inch tumor that was down by my rectum and the bladder area where I had the problem. So my daughter was getting married in 4 weeks. I couldn't do the surgery then. And we had some other things going on that summer. So it was in October of 2009, I had my second chemo bath. Again, had an ileostomy. Had that reversed, and here it is 2 years later. I'm healthy. I'm living proof that IPHC works. And I know there's a lot of medical facilities in the country that don't believe in it, as the doctors have presented. I did have a minor scare in January. I went back in after a 6-month hiatus, and I had the scan. And Dr. Bartlett said the radiologist found what he thought was just a shadow down by my bladder again in the same area where I had the problems. And he said, it looks to me it's just a shadow from the contrast that you bring for the CT scan. He said, just to be sure, come back in April, just test it to make sure there's no problem. So I came back in April, and I don't know if you knew Dr. Bartlett. He's a pretty jovial, nice guy. He came in sort of downtrodden and sullen, and he said, well, the shadow is still there. So the roller coaster starts back down. And so I said, well, I had so much surgery, could it be anything else? And he said, well, maybe a 10% chance of something else. He said, but just to be sure, let's have a biopsy. So I had the rectal sonar biopsy. They aspirated the area 4 times, and it came back as a benign lesion. Thank goodness. It was just scar tissue. And here I am 2 months later, and have the honor of speaking to him. And that's my story. I did fail to mention my official diagnosis is mucinous adenocarcinoma of the appendix. And I guess I don't hear this term too much, but Dr. Lambert did talk about it. But my spectrum is moderate to well-defined. I know a lot of PMP patients online and stuff. I don't see that discussed too often. So if there's any questions in the audience, I'd be Dr. Shirley.
Was it for sure from the appendix, or was it from the urachus?
I don't know what a urachus is.
Was your appendix definitely involved when Bartlett did the surgery?
When the general surgeon out at Excella did the original surgery, he said my appendix was gone.
It was gone?
Yes, it did not exist. I never had any problem with my appendix prior to that.
So that sometimes the mucinous tumor eats the appendix.
Right.
So it probably was a high-grade appendiceal, and the appendix just gets destroyed.
Right.
So that's probably right.
That's
a lot of people who have bladder symptoms first, they actually have a even rarer tumor of the dome of the bladder associated with the urachus, which is a structure important when you're in utero, not afterwards. But we've had a number of people who have thought they had appendiceal PMP, but they actually had urachal PMP, and their symptoms were usually, or actually almost always, they were always related to the bladder as a presenting symptom. And a lot of them were urinating mucus.
Oh, that happened to me.
It did?
Yeah.
Okay.
There were bits of it that had come through. Yes,
As a patient, what do you find that was more of a problem to be treated? Now, we were lucky that many of patients are today that you get to a doctor because you know a doctor who knows the doctor or a friend that has had your same problem, but usually not from the treating physician. What do you think in whole therapy going through all this is missing that we as physicians or institutions need to focus change the quality of life of people undergoing these procedures?
Well, I was a lucky one because I live near Pittsburgh. I'm only 30 miles from it. And my oncologist knew of Dr. Bartlett and worked with him in the past, so I was very lucky. I know other patients they spend months trying to find someone and they have no idea who to talk to, and they have general surgeons that do surgery on them. And what I've learned, and I guess that's some of the worst things that can happen. You have someone who doesn't know what you're dealing with. I wish I had a recommendation, but I really don't. I'm lucky because I was local. Any other questions?
Maybe before we leave today, we could, from the group that's here, get an idea as to what you, and this actually is follow-up on Armando's question, get an idea from you as to what you think is necessary for a center to say, I'm a peritoneal surface oncology referral center. What's necessary?
That's a good question. We'll talk about that.
I mean, you have to have a hotel. That's part of the hospital complex. So whether you're there for 2 weeks or 3 weeks or for all your tests, it's convenient. Do you have to have a relationship with both medical oncology and surgery in order to feel that all the bases are being touched? I'd like to know from a patient perspective what's really important.
Okay. Thanks. Have a good week.
At UPMC Shadyside in Oakland, near their headquarters, they do their Shadyside Hospital has next to it a Courtyard by Marriott. They have the hotel, and they also have something called Family House, which I think it was an older home that they had redeveloped, and they actually keep patients and their families in there that have to be there for an extended stay. I think that might be atypical. I'm not sure, but Shadyside is set up to handle that type of situation.
I know that the Ronald McDonald houses all over the country, which are very much appreciated.
Yes, sir.
Good morning, everybody. My name is Dr. Randolph Nunez. I'm a proud patient of Dr. Sugarbaker, and I can answer that question. I went to Sloan Kettering in 2007, and I was given a 5-year survival rate of 10%. And I researched as much as I could and almost didn't have a conclusion. But my best friend found Dr. Sugarbaker, and what families want to hear is that you're going to survive a certain amount of time. And your 10-year survival rate was what caught my eye. I mean, compared to 10 versus 80%, because I had mucinous adenoma. So it was a pretty benign, but yet, as everyone knows, any cancer in the peritoneum is aggressive over time. So what patients and families want to know is what's their survival rate compared to what's going on out there. And if you want to forward families, it's to educate the surgical oncologists that are present in the United States to know that they can't handle certain conditions. Because, Sloan Kettering is a center that I've rotated in as a physician, and I highly respect. But what I've come to realize is not every cancer is for every institution. So there are specialized centers, Pittsburgh, Washington, in Baltimore, and now in UMass, where I'm actually from Worcester, Massachusetts, so it's very nice to meet you. We need to definitely create awareness that these centers exist. And thank you for...
Good comment. Yes, Doctor.
Could I ask Dr. Nunes, how did your insurance company treat you?
Well, my wife is a semi-Laurie, the insurance warrior now. She graduated from med school with me, and she has battled she's actually just won a $900,000 appeal for one of the other patients. It's her 10th one. So she's taken on a role as an advocate for patients also. My insurance didn't cover it, but through her appeal, because of Laurie, we were able to win that, and I only paid a minimal amount compared to what the gross amount was. So we are becoming advocates for the patients. Obviously, it's a large number, but the insurance companies are now starting to lose their battles as long as you continue to use the appeal process. And so that's something that's definitely coming about.
Well, my insurance company is Highmark Blue Cross Blue Shield, Western Pennsylvania, and they've covered 100% of it twice. And I know other or Blue Cross Blue Shield programs throughout the country don't even recognize it.
University of Pittsburgh has done a spectacular job of integrating themselves with the insurance companies of Pennsylvania. It's not so good around the country, and I can tell you it's definitely not so good in the District of Columbia.
I just want to make a quick comment. I'm the wife of a PMP patient, and she's had a number of surgeries at Mercy with Dr. Sardi. And back to your point about what patients need, I think that that Mercy is doing a lot of things right, and I know that Dr. Sardi has been the impetus for that in terms of, especially for patients coming out of town, having one person on his staff who coordinates the start to finish experience and gives them, this is the hotel where you can stay, which is right across the street, has discounted rates, has suites for when there's recovery that, they're going to be out of the hospital but need to come back and see Dr. Sardi. It's right there. And Dr. Sardi's done an amazing job of coordinating from A to Z every, resource that Mercy has to offer that is, the patient is introduced to it on their pre-op day, including, some of the spiritual and pastoral care that Dr. Lambert was talking about. You see the stoma nurse, you see the physical therapist, you see the occupational therapist, you see them all the day before the surgery, so you know what to expect. And I think that for us, it's just made the experience so much easier. I think that we all are just looking for knowledge, and especially with such a big surgery, it's such a scary thing. And to have this sort of complete introduction of all the people and everything that's going to happen to you, and this is what to expect, and these are the tubes, and this is where they're coming from, and then when it's actually happening, you understand it so much better. And I just really think that, I don't have anything to compare it to, but at least in my mind, it seems to be a model of how to deal with this for patients and make them comfortable and make them be able to handle it. And we've handled it 3 times, so and it got easier each time, and I think just knowledge and understanding.
How far do you have to travel to get to Mercy?
It's funny, we have the same story as Mike. We were, my husband was diagnosed quickly. I lived across the street from a gastroenterologist at Mercy, and I called him, and he's like, I know the guy. And we live in D.C., but we're just an hour away from Baltimore, and I think that, unfortunately, for me as a caregiver, the most important thing that got me through it was being with my family and being close to the center. And I could stay at my parents' house and, go home for 15 minutes and a 15-minute drive and be able to do laundry and get something to eat. And that was crucial. And I feel so lucky to have that for so many patients.
Because most patients are coming from 100 miles, 1,000 miles, 4,000 miles, or sometimes from halfway around the world. And having something ready for them when they come is something that some centers have and others do not.
I know at UPMC, I always offer to help mentor new patients coming in, and I'll be on the websites and things like that. And one of the gentlemen that, I guess the last 2 that I talked to, at UPMC, they actually do the exact same thing. They run people into the ICU. They get to meet the ICU nurse and talk to them about everything that's going to happen to you. And one of the disturbing things that my wife and daughter went through was when I had the first major surgery. Apparently, they pump your body with fluid, and when she came in to see me, I looked like Shrek. I wasn't green. I was just swollen. I just remember waking up and my fingers looking like hot dogs. And it was just incredible that they blow you up like that. She had no idea. She wasn't ready for that. But apparently, they are taking care of that type of concerns of patients now. They run you through the whole gamut of what's going to happen, the different types of things you're going to see. Yes.
More of a comment, this is another thing that we as healthcare providers have to keep working. Dr. Sugarbaker mentioned there's 120 centers. There's 6,000 hospitals in the United States. So that means that less than 2%, because of the 120, some of them, they just have a machine. They don't do actually a number of cases. So less than 2% of the hospitals provide this. So we have to work on training physicians to do this. There is not one single official training program in cytoreduction and hyperthermic intraperitoneal chemotherapy. So we have a lot of homework to do.
One thing that we have put together along with the patients is a booklet that we give to the patients in each consultation that goes through, especially the quality of life after surgery. We don't do these massive operations, and there's diarrhea, there's sexual problems, there's a lot of issues that are not even mentioned throughout. And that is something that people are living and having a good life. We have to improve their quality of life long term. Because people are doing very well from the surgeries, from the cancer point of view, but we are missing other areas that we need to put more attention.
Any other questions, comments?
Well, we can obviously continue some of the questions in the panel discussion later.
Thank you, everyone.
Thank you.
So in keeping with the switched program, we're now going to do the case presentations. I think there are 2 case presentations actually from locally here. But Dr. Sardi, Dr. Armando Sardi has agreed to share a case presentation first and then maybe help moderate the other case presentations going forward. Dr. Sardi is director of the Institute of Cancer Care at Mercy Medical Center in Baltimore, and also the director of the Surgical Oncology Division. He's a widely renowned surgeon and uses cytoreductive surgery and high-tech to treat late-stage complex tumors in the abdominal region, which is kind of a theme. Dr. Sardi is also a clinical investigator for the National Cancer Institute and is committed to research and the management of complex cancers. He has numerous publications to his credit and has lectured nationally and internationally, educating and training physicians regarding the treatment for a variety of late-stage cancers. And Dr. Sardi, again, also volunteers his time as a member of our professional advisory board, which we obviously appreciate. Without further ado, Dr. Sardi.
Thank you, Gary. First, I really want to thank the PMP Foundation and all of you that really has made this possible. The only way we are going to make a difference is by patients really making it happen. So they don't believe the physicians anymore. All the time when we used to say something and people say, yes, doctor, it doesn't exist anymore. I mean, it's changed completely. So I think this type of program that you are doing and can reproduce this throughout the country is what is going to make a real difference. Even though we are seeing more patients earlier, I will say that over 90% of my patients are already advanced, so have multiple operations, multiple therapies, and so on. Interestingly, from the financial point of view, I had a lady which is 3 years out since the high-tech. She was treated for 2 years with chemotherapy, and she actually had to have DPAM, which did not need chemotherapy after the high-tech. She brought her bill from Medicare. She was 68 when we did it. She's now 71 years old. And the cost of Medicare for the chemotherapy for 2 years was $1.9 million. Although the Medicare refuses to pay the surgery that, depending on how it goes, maybe for $40,000, $70,000, and not realizing that the dose of Avastin is $10,000, and one dose of old folks plus Avastin is $30,000 to $40,000 given every 4 weeks or 3 weeks. So I think that we need to be aware. The other thing I think is important as an organization is try to see if we can, the websites. If you look at the websites, the only people on the website are people who are dying with all kinds of problems. The people who are doing well, the people who are going on with their life. So we need to find a way to do a more upbeat, the patients, they come to see us crying. They say, I'm dying. I say, what happened? What's going on? Not only because of what they spoke to the previous physician, but when they go to the internet, which is what most patients find out at this time, it's amazing. They only see terrible stories. So I think the ones of you who are doing very well, you open a site and really talk about having children, and traveling, adopting children, because the stories are amazing, and I think that is something to remember. I think we need to train more physicians. I think the people who are doing it, won't be here forever. And I think unless we train more people, there's no reason why people should go from state to state looking for the right therapy in the United States. Okay, what I'm going to do is try to present. I'm going to actually jump to the second case first. because we want there's another presentation going on. And let's see if I can do this. So this is a 33-year-old male who presents with 1 month history of abdominal discomfort, abdominal distension, and diffuse ascites. The CAT scan, which I'll show in a few minutes, is rather extensive. He underwent negative colonoscopy and EGD, and underwent diagnostic laparoscopy to 3 port sites, which time biopsy was taken and 5 liters of ascites was removed. And this is the CAT scan, right? Impressive. There's pretty much involvement, as you can see, stomach and ST, colon, pretty much look around behind the. Let's see, we have behind the stomach, you can see tumor, here's the pancreas, and so on. It is actually moisturing or cauliflower appearance of the small bowel in some areas, the rectum extended, and you can have to see how much impeachment in the pelvis. So the biopsy of the laparoscopy showed fibrous tissue. Sorry, I'm going back here. Fibrous tissue with chronic inflammation and full of extracellular mucin, with some blunt epithelium. No minimal cytologic atypia, no mitotic atypia, and it was considered deep. So I wanted to see to the doctors here. How do you use? I mean, is this patient that should undergo high tech? How do you consider exclude? What patients should be excluded? How do we? Dr. Baker, Dr. Lambert, any comments?
Would we exclude this patient, Armando?
Would you exclude this patient?
No, I would not. But I would think that it's a challenge. That CT is impressive. It's a very good pathology report. It's quite a difficult CT.
So how do you use the CAT scan to make a decision? Because for me, it's one of the problems. Sometimes I see CAT scan that look terrible, and I go in and it's completely opposite that I suspected, and vice versa. I see something that is beautiful CAT scan, you go in, and how should we use the CAT scan and to make a decision?
Yeah, well, that's one of my areas of interest. I always try to get an idea before you take a patient to the operating room. And so I may incorporate 3 things. The symptoms of the patient. If the patient is bedridden, throwing off and, DPN with a CAT scan like that. Then the amount of tumor on the CAT scan, but most importantly, you have to combine all those 2 with the histology. If that CAT scan was from a patient with colon cancer, then I'll tell you, I don't need anything else to tell you that that patient should not be operated. But on the other hand, if it's a true pseudomyxoma, we always said there is no exclusion criteria from the PCI or from the CAT scan. So it depends, especially in a 33-year-old, and you get a lot of information also, I'm sure, when you examine him.
Oh, yes, it's a bulgy stomach, healthy-looking male,
Right.
and concerning was, if they have removed 5 liters of clear ascites, which is not typical pseudomyxoma.
Right.
But Dr. Lambert?
So I obviously share your experience. I think we all start with some imaging study, the CAT scan or now MRI more commonly, and I think we carry some things that we consider relatively strong contraindications, multiple levels of bowel obstruction. If you see that cauliflowering of the mesentery, you know that the mesentery of the small bowel is more likely involved than what you may actually see. Biliary obstruction, ureteral obstruction becoming, it's still a concern if you see that, suggesting a more invasive type of tumor. But then, like you said, you really just don't know until you get in there and you take a look at it. You've got a 33-year-old guy with a pathology that's not, cancer, and your experience is that you can often get this stuff out. So, and you already have the laparoscopic information, but if you didn't, that might be another place to start if you are concerned that, the CT scan may be underestimating the true situation. So I start with the CT scan, but it can go one way or the other.
It's actually interesting because the laparoscopic reports are usually very inaccurate. And actually, I called the surgeon and I say, how does small bowel look like? Because this for us is very important as a quality of life and the ability to actually remove the tumor. And he said, I didn't look at the small bowel. It looked bad, but So you really didn't get that much information, but this is the typical information. They see a lot of